first tubule. Yep, similar first tubule dysfunction. What cardiac complication are you most worried about with kids with Marfan syndrome? The aortic dissection. What part of the aorta? The root. Good. Okay, so those were specific. So that lecture, in my opinion, is a lot easier because there's very specific things. It's on this gene, it's going to cause this phenotype, this is what you can expect to see. This next lecture that we're talking about with developmental, so remember this is not their growth, this is their functioning, is more of a legal case. And the reason I say that is because in this case we're looking at what does the preponderance of the evidence show. Is there more things in favor of this diagnosis or less than? So most of these are not going to have specific labs, specific imaging. It's going to look at what is the pattern of behavior that is predominant, and does it meet that preponderance of the evidence definitions? It's going to be a lot of things when you're providers that you're going to have to make that call on. Does this seem more like this? More like this? How are we going to make this diagnostic call? So I think this is a harder lecture and harder things to grasp, much like your psych class. Is it sophomore or semester? Because it's a lot of, do you meet this criteria? It looks a lot like this. What do we have going on? And so not always as straightforward. So we're talking more about the development and your functioning. Your blueprint, just if you're wondering where it starts. So we're going to start by age. We're going to start with neonates and work our way through that. So a lot of these are going to be those common complaints, but how do you make that diagnosis when you have these? So the first thing that we're going to talk about with infants is crying. Right? So we don't think about crying as a diagnostic entity, however, it really is. But when you think about what crying is, it is just infant arousal. That is all. So that is really the only way that infants are going to communicate with you what is going on. And they will do that to any type of change. So I woke up, I cry. I want to go to sleep, I cry. I'm hungry, I cry. I have a dirty diaper, I cry. That is my only form of arousal at that point. So normal to cry, you're having to decide what is normal, what is abnormal inside of that entity. People will, if you haven't been around a baby, most of the time, the cries, they'll vary in their duration and their intensity. However, a baby who is really hungry can get up to like 80 decibels, right? So it can be very, very loud and will increase if they are unattended to. So that would be one thing. So painful cries are certainly going to be on that higher end. Hunger cues will eventually lead to those painful cries. The thing to know, so a specific pattern about crying, if you haven't been around babies, is that it usually clusters in the early evenings. So right around dinner time, so it's a perfect setup for families, right? You've been at work all day, now you get home, and now the baby starts to cry incessantly. Right? So you take a mom or a dad who's been on paternal leave, now you put them back into a work environment, now they're picking up the child, or they're coming home to a child who is crying in those specific times. So we kind of refer to that as the witching hours, that early evening time frame. Okay, so just know that pattern for me. You'll need to know that. So how much are they actually crying? If you really looked at the numbers and studied babies, you would see it when they're very first born, if you collectively took the amount of crying that they did throughout a day, it's about 1 to 2 hours. So not in any one period of time, but you're looking at collectively on that time period, about 1 to 2 hours. That will increase and usually peak about the 6-week mark. So right around then, they're usually crying for no more than about 3 hours. But 3 hours is not an insignificant amount of time, right? That's 15% of the day is spent crying. You go back to 12 weeks, and they're back down to about an hour a day for a typical child. One thing that we'll talk about in PEDS, it's not a real thing, but there's a developmental entity. So in those first 3 months, there's a whole lot of development. So we kind of term that the 4th trimester, right? So it's a postnatal period, so it's not a trimester, but there's a lot of development that happens in those first 3 months. So if we ever refer to the 4th trimester, that is what we're talking about. So most of the time, after that 4th trimester, after that period of 12 weeks, you typically see the crying go dramatically down. So that's the typical pattern of a normal baby. So what is not normal? So how are you going to diagnose or say what colic is? So colic is when you have crying that doesn't fit that pattern. So the pattern of it's usually 1 hour, then 3 hours, and then down, not necessarily that. So they are crying well above 3 hours a day, and for more, they have to be more than 3 days a week, and then under that 3-month mark. So those were the old kind of rule of threes. We now added that they have to be under 5 months before this starts and stops, right? So if you have a 1-year-old who's doing this, we are no longer in the colic range. So under 5 months when it starts and stops, they're inconsolable with parental engagement, right? So if you have a baby that is crying, you change their diaper, they're just fine, that is outside that definition of colic. With colic, you have fed the baby, you've changed the baby, you've rocked the baby, you've soothed the baby, and nothing is helping. So inconsolable. And then still the 3 hours more than 3 times a week. So the last one gets me. If you can choose to practice however you want when you get out. However, if you tell a family, I need you to go home and for 24 hours, measure exactly how much they're crying and bring that back to me so I can give you this diagnosis, they might kick you in the leg, right? That's a hard one to do. A lot of times they're coming to you because they already know that it is outside of that standard amount. So we'll typically peak at about that 6-week mark when you would expect it to peak with everybody else, but it is outside that norm. And it is an equal opportunity offender. So breastfed infants, bottle-fed infants, girls, boys, different, doesn't matter the race, doesn't matter class, doesn't matter anything. So baby's gonna cry. So that is one of those exclusions. We'll talk about what kind of workup would you want to look at for some of that. However, you really don't see anything long-term with this. It's going to increase your risk potentially for maternal having some postpartum depressive type symptoms, which makes sense. We take a sleep-deprived mom who's already having hormone withdrawals, and now we put a crying infant who is outside of that standard deviation on top of that. You can see how that results in that. There are some really interesting studies. This is not in your textbook, this is just free. But there's some studies that are looking at infantile colic and migraine headaches in some families. So if you are one of the people who has a family history of migraines, maybe call your mom, text your mom, and say, did I have colic as an infant? Something kind of interesting to look at. So nothing definitive there, but kind of starting to look at some correlations. Also, is it really hot here today?
Yeah.
Okay, I was like, is this just me and I just want to fall off this podium, or is it real hot? Is it just like not working today? Welcome to Metco. Okay. So this is kind of what these are the things to know as opposed, so yes, knowing the patterns, yes, knowing your questions, so it's going to be your standard OPQRST that you're going to ask. One thing that I will specifically say is there a feeding association? The reason I need you to ask, is there a feeding association, is because babies don't do a whole lot of exercise. Remember, they're in their cockroach stage, they're just laying there doing not a whole lot, right? So they're not doing a lot of exercise. So what is babies' exercise? Crying and eating. So eating is their exercise. And so if they are having discomfort and pain with eating, that's the same way as if we started exercising and there was pain. So one of the things, particularly if you have pain with feeding, you're looking over on that list of differentials, the thing that you need to think, is there an anomalous coronary artery? So when they are exercising, is it taking away from your coronary blood supply? Right, so that should be on your differential. So if the baby has problems exercising, aka feeding, what is going on with their heart? Similar to an older patient if they came to you and said, hey, every time I try to go out for a run or a walk, my chest starts to hurt. Other things that it could be, if you've ever been around a baby, where do their hands typically live? Is it down by their sides? Is it up by their face? It's up by their face, right? Babies also, this is not going to be in your anatomy textbook anywhere, but their fingernails are like little dragon claws, right? So their little dragon claws that live up by their face love to go after their little corneas. So it's pretty common for a baby to give themselves a corneal abrasion with their tiny little baby dragon claws. So that can be one of the things on your differential. You can have hair tourniquets as well. So you can see that. Typically toes, fingers, penis. So checking the diaper region to see has a hair gotten caught and twisted around. Certainly any kind of fracture. We have a whole child abuse lecture, so we'll talk about that. We already talked about the coronary artery. Is there something going on with an acute abdomen? Do they have an incarcerated umbilical hernia, inguinal hernia, something going on there? Any kind of mom medications. And then the one that I want to hit is UTI. So for the rest of these, are you really doing a whole bunch of labs or radiology? No. For a UTI, you might want to do that. This would be the one indication to have a lab here, because infants aren't going to mount a response with a fever most of the time. They can't tell you, it hurts when I pee. They don't concentrate their urine very well, so that can be one of the things you see with recurrent and repetitive crying that looks like colic. So your one kind of standard lab that you might get for colic to rule something out would be a urinalysis and urine culture. Remember, those marry up with PEDS because the urine doesn't concentrate because they just pee immediately into their diaper. So urinalysis and urine culture go together. So kind of really your only standard lab for colic. If you like to study this way again with charts, this will get you down to the same things. Basically, they are going to have urine and urine culture as your only standard lab in a workup of colic. So what is your prevention then, or what is your education, what is your treatment that you're doing? So a lot of that is making sure that parents know what is normal, what is abnormal. If you have a 19 or 20-year-old parent who's the first time away from home, first child, and now they're in the military and they come to you and they're saying, I don't have any idea what this thing does, it cries a lot, you tell me what to do. You need to know what's normal and not normal to be able to normalize things, educate the families. Other things to think about and things that you can do. Anytime something is in the baby's mouth, they will start sucking on it. So there's a lot of times where, especially if you are bottle feeding, you can easily get in a situation where you are overfeeding and causing recurrent discomfort, because as long as there's something in the mouth, they will often suck on that. Lactose intolerance, they don't have the lactase enzyme, can be one thing that you might see. So certain things to try would be, if mom is breastfeeding, to have her cut as much lactose out of her diet as possible. So those hidden sources of lactose, butter is a common one, creams, anything that has lactose is going to be something that mom could take out of her diet to see if that improves breastfeeding. And then another possible treatment that you could try is a probiotic. Again, is it probably going to completely fix colic? Probably not. Might it help, and is it going to hurt? No. So it's something to talk with your patients about. Very little side effect, some potential benefits. So that would be one certain things to try for your if you meet that diagnosis of colic. When you're in the hospital for your rotations, you might hear about period of purple crying, and that is an education tool to be able to talk to families about how long do you expect this to last, how long is the crying, what kinds of things can they try. So if you hear any docs, nurses, PAs, anybody talking about the period of purple crying, that is basically everything we just talked about with colic. Yes, ma'am? You can give it to baby, yeah. So mom can take it as well. It just doesn't cross over into the breast milk very well. So yeah, this would be given directly to baby, which is an interesting point. This is, again, just for free. The DoD, if you are active duty, will often have some of they will get the generic brand of medications, and they are often the cheapest ones that are available. So the vitamin D that the DoD provides, what dose was the infant supposed to have? 400 what? IU, which is international units. Yep, that amount they give and the concentration of it is really, really disgusting. It's a large quality. It's 1 ml, and so it gets everywhere. It smells disgusting. Or they could buy it over the counter, and there's often vitamin D plus probiotics that is 1 drop, and it smells and tastes delightful. So that is just one those type of medications you will learn that if you're active duty. So that one's free for you. Temper tantrums. So we've gotten out of our neonatal period, and we are starting to get into temper tantrum phase. So what is your actual definition of a temper tantrum? So some sort of extreme frustration and anger So many of you are thinking, wow, this is me right now. Right? Screaming, stomping, hitting, head banging, biting, breath holding, vomiting, all of the different things that you would think when someone has extreme frustration and anger and is yet unable to communicate this expressively. So often this will go with children who have some sort of a language delay with expressive language because they are having trouble explaining why they are so angry and why they are so frustrated. Usually 1 to 4 years old, so will you sometimes see this in a 5 or 6-year-old who is completely melting down in the grocery store? Absolutely. Do you expect to see this in a 9-year-old? Maybe. Do you expect to see this in an iPad student or faculty?
Yeah.
Yeah. So most common in the 2 and 3-year-olds, one of the reasons you've heard of terrible twos, for 3-year-olds, they call them sometimes three-nagers, because they act much like a teenager, throwing themselves on the ground. Equal boys and girls, and typically is going to be between 2 and 5 minutes. So what are you looking at? Because you're seeing, you're like, stomping, hitting, head banging. What is happening, right? This seems extreme. So this is how you're going to determine what's normal and then what's abnormal. Remember, this is one where you're really going to look at the preponderance of the evidence, right? Does this 5-year-old have an absolute meltdown that lasts for 20 minutes inside of Kroger because you didn't buy them a candy bar? Maybe. And does that mean they need a specific diagnosis? Probably not. Is this something that happens every single day because they can't express themselves and there's something going on? Potentially a different story, right? So if we're looking at this, what is this going to happen? So normal ages are going to be between 1 and 4 years when you start seeing this. So past the age of 4, where it continues persistently, is outside the norm. During the tantrum, you see them flailing, hitting, screaming, biting, all the things you think of for a temper tantrum. What would be abnormal is if they injure themselves doing that. Right? So families a lot of times will say, but they're banging their head on their crib, they're banging their head on the floor. Absolutely normal. What is not normal is if they are injuring themselves with that. Okay? So kids will self-limit and try to scare the adults. They're not going to injure themselves. So an injury to self is outside that normal range. Up to 15 minutes is considered normal, typically 2 to 5 minutes. So if this is persisting 20, 30, 45 minutes, an hour, that would be outside the normal range. Typically less than 5 times a day, can be more than 5. And then they should return to normal between this, right? So if you've been around a child and you say, we're not going to the park, they will melt down, 2 to 5 minutes, then life is over, and then you say, do you want a grape? And everything is completely fine, and we have moved on, right? That's the normal pattern that you see for these children. If you say, we can't go to the park because it's raining, and the entire day is ruined, that would be outside that normal range, okay? So please be able to distinguish what is a normal temper tantrum and what is outside and a developmental concern for the test coming up. Triggers. Everything that you would think would be a trigger to a human is a trigger to the child. Think about yourself. When you are tired, hungry, sick, or in periods of transition, it's not going to go well, right? So my mom used to say it, and it's super true. A snack and a nap is going to help most things, right? It's going to help with the children as well. Particularly times of transition, and this is going to be as a provider, you're looking at where are the transition points that this child is having trouble with. If you think about the military, we double down on that, right? So now we have all of the moves that we're going to do. O plus TDYs, O plus deployments, O plus we're out for training, mom or dad's out in the field, oh, we're not home, we're moving, we're all over the place. Special duties, changes of schedules, we're working this holiday, whatever it is. So you see this in military kids even more ramped up because we have more periods of transition. So then it would make sense of how do you help these families with this sort of evaluation, and education is looking at how do we combat those things. So your evaluation, as always, is going to start out with your standard. Yes, sir?
This might be a bridge too far, but is there any correlation between like abnormal tantrums and then developing adjustment disorder later in life?
I don't know. I'll look that up. Adjustment disorder with bad temper tantrums outside of that? I don't know. I'll look it up. Let me write that down. That's a good question. we'll get back to you on that. Yeah, so starting with your history and physical, making sure you have a good history on that back end, looking at what are their patterns, what are their daily routines, do they even have them? We had some young families when I was at PCM that literally had no schedule, zero schedule, and so the kid obviously didn't do as well because there was no predictable patterns here. So we'll talk about that in just a minute. Is there some sort of family stress that has changed in that interim? Is mom or dad deployed, grandma has moved in, and everything is in complete upheaval? And then is there anything underlying that you're going to be able to find? Because that's going to exacerbate any kind of developmental problems. Again, this has a lot to do with that expressive, so any kind of developmental language issues certainly are going to make this worse. Something to check and consider in this age group, especially with the development and behavior, is do we have iron deficiency or do we have lead toxicity? So do you remember at what age you get those draws of lead and an iron check? 12 months. When do you start screening questions for iron? All the way up to 6 years. Good. And then parental education is going to be key for this specifically. Your treatment then is going to be encouraging as much routine as possible. We all understand time in this room, or maybe we don't, I don't know, it must feel like you guys have either been here forever or not for very long. But children do not understand the concept of time at all. If you've ever been around a child and it's like Amazon's going to drop off a package today or in 24 hours, like they'll ask you every 15 minutes because there's zero concept of time. What they understand are patterns and routines. And so if you can get them in a pattern or a routine, that is the best way to help them understand time and what is about to happen and what is going to happen. So as much of that as possible. Also taking away the unnecessary triggers. Remember, children are miniature humans, right? So if you are like, I had a really stressful and a really bad day, I'm really tired and I'm hungry, maybe not the best time to go to the grocery store. Maybe not the best time to have a big discussion with a spouse, right? It's going to be the same thing for a child. All of those same things, along with positive reinforcement, can go a long way for those treatment of your temper tantrums. One thing that you will see that's a little bit different, I guess if adults do this, let me know, I guess that would be abnormal. But children, this will be a remnant of that neonatal response. So if you remember way back in the first lecture, a neonate's response to hypoxia is apnea rather than tachypnea. So this is a remnant of that, is a breath holding spell. Where a child during a tantrum will hold their breath to the point that they go apneic. Will get hypoxic to the point of apnea. Super normal if you're 6 months to 6 years old, so right in the middle of those temper tantrums, the 2 to 3 year olds, very, very normal, and that will really freak everyone around you out, right? So if this child is hitting, screaming, fighting, and then holding their breath to the point that they pass out, it's going to freak people out. You now know, completely normal, they're in that age and in that stage and in that range. Everything else is normal. What you will see is their body is going to try to get them horizontal. So if they are hypoxic, it's going to get them horizontal. So they will go down, and sometimes have a loss of consciousness, and then it will be what some people will describe as a seizure or seizure-like activity. Most of the time, it's just a myoclonic jerk from a brief period of hypoxia. So not a true seizure disorder, not something that you need to work up for a seizure disorder. Again, iron deficiency is going to be important. And you can use this extinguishing technique of just ignoring this as long as the child is in a safe environment. Yes, ma'am?
Is this a situation where like you have to take the ER completely on evaluation?
No. Completely ignore it. If they fall within that normal pattern, you leave it alone. They do not need to go to the ER. They don't need a full workup. Okay, so check on learning. More common to see colic in the evenings, yes. Does it have any preference for breastfed, bottle-fed, boys, girls, economic? And then why is E wrong? What is the age, the upper age limit? 5 months. Yep, so when is it most common to see? 6 weeks. Okay, so we are marching on up. So the next group of kind of the children is going to be your children with special needs. The reason this has specific application is that if you've been in the military longer than about a week, you might see that there is an increased amount of children with special needs in the military. Why is that? Well, we have great coverage with TRICARE for different types of therapies and different access to specialists. So a lot of families will come into the military specifically for medical care for their children. So the average number is about 1 in 5 children that's going to need some sort of specialty care over the course of a lifetime is much higher than that in the military. So something that you will probably see. So anything that has any domain, pick a domain, physical, mental, social, emotional, behavioral, any of those can fall into this category of special needs children. So unlikely that you will be unscathed by this by the military. Even if your soldiers don't have, or airmen, depending for the Air Force or Marine folk. Just Marines. Wow, that was really dumb. Never scratched that from my husband. I thought you guys had whatever. You might not see them in your population, but their families are going to be affected by this. That is how it is going to relate to you. So what is our goal then? The goal is to get this child to their maximal potential. That might not be inside the standard deviation of what is considered normal, but that is the child's maximal growth and developmental functioning potential. And then helping the family manage any kind of stress and expectations with that. So one of the things that you will see is that families, particularly with their children, will go through the stages of grief for any kind of, or potentially any kind of diagnosis. So I used to think, well, that would probably be if I gave them a brain tumor diagnosis, if I gave them a leukemia diagnosis, if I gave them a diagnosis of a genetic disorder. And that really wasn't my experience. I had a harder interactions and harder time when I would diagnose them with something that maybe wasn't as big of a deal to us. So I think the worst interaction was an example where I diagnosed this child who had recurrent bouts to the ER with a diagnosis of asthma. And I'm thinking, this is great, this is easy to treat, right? We can get this kid a couple of inhalers, they're gonna be great, they're gonna be back in soccer and doing all their things. The dad just absolutely lost it inside of the appointment because what he had just heard is, wow, we have 5 generations of military service. You just gave me a diagnosis where all of my hopes and dreams for my child are completely destroyed. So they go through these stages of grief, and sometimes it will catch you off guard because you're thinking, I just gave you a diagnosis, this is great, and you completely destroyed their world. So something to think about when you are giving people different diagnoses. It might be something relatively benign to you, and that is not how the family takes this. So it might be the same for your adult patients, but is particularly pronounced when it's children involved and you're telling parents. So why else do we talk about this here? Well, because the military is a specific model of the medical home. So if you've never heard this, you're going to hear this a whole lot under DHA. So the reason that a medical home is really just another way to say there's a centralized hub of one person who's kind of directing traffic. So if you're ever wondering, why is the cardiologist saying that I should order XYZ? It's because you are a medical home, so it's going to come back around to the PCM to coordinate care between specialists, to coordinate referrals, to kind of help with that care coordination. So the patient has one central place to go. This will supposed to help families have a little bit more control and know who to go to, who to talk to for certain things. So you're thinking, well, what does that mean that I'm going to do as a provider? It's basically everything on this list. So everything that you've started to hear about throughout phase 1 that you will see in phase 2. So any kind of referrals back and forth. If you see something that the cardiologist says that is in direct conflict with what the nephrologist says, this would be, you are the person to help correlate and connect the two to say, how are we going to best manage this patient? How are we going to do environmental interventions? How are we going to work with the families to make sure that they get what they need in and out of the house? So one of the things to be aware of as well, if they need durable medical equipment, we'll hear DME. DME is its own separate referral. So if you need wheelchairs, if you need adaptive equipment, you need special prosthetics, you need any kind of things like that, there's going to be a whole separate entity. You're thinking, oh, I don't know what the physical therapist specialist or occupational therapist says that they need for this type of XYZ, that's what the medical home is for, to help coordinate care between all of those things. What else was I gonna say? This is the best way that I had this described to, because you're like, yes, we know all of this stuff, is you are going to be tasked as a primary care PA to interpret a very complicated medical system and a very complicated specialty care language, and you need to translate that into human. Okay, that is your job as a primary care manager, is to get all of this complexity into human. So, and then your patients will love you for that. There'd be times where I particularly remember this one family that this child had this incredibly rare genetic disorder that I didn't know anything about. Never heard of it, never seen anybody with it. I think they went up to Cincinnati once a year for their specialist. Like, I didn't know anything about it. And yet the family would come back and ask me, do you think we should take what the specialist is saying we should take? Sure, I don't know, right? But it's because we have built a trusting relationship where that my opinion mattered to them just as much as the specialist does, right? So these are the types of things and relationships that families and you will build over time in this profession. And so don't take that lightly because it's a big responsibility for you guys and for me. So we're gonna get into a little bit of these older kids now. So one of the things and the diagnosis that you'll need to consider is intellectual disability. So the old terminology used to be mental retardation. So if you see that in text or studies, older studies, that is now no longer the term. We will call that intellectual disability. And this is really looking at the functioning for whatever their developmental age and stage should be. And is it outside that standard deviation of 2? So if you're looking at intelligence or an IQ, average is going to be 100. If the standard deviation of 1 standard deviation is 15 points, below 2 standard deviations is going to put you at below 70. So below an IQ of 70 is considered intellectually disabled. So onset is going to be before they are adults, so before the age of 18. We'll talk about, so between 6, I guess 5, and 18 is sometime where you see that. So if they're below 5, they don't meet that definition, and instead, it is called global developmental delay. The reason that you're seeing this is that, remember the 5 domains that we talked about? So we have gross motor, fine motor, communication, personal, social, and problem solving. We looked at those ASQs. You expect to see 1, maybe 2 domains affected. If you see every single domain affected, you see that in multiple domains, multiple standard deviations outside of that, instead of having an intellectual disability diagnosis, because they are in that high time of growth and development, it's called a global developmental delay. So why do we make that distinction here? Why don't we just call it intellectual disability all the way around? Well, because they are in those high times of development, means that interventions can significantly matter here. So if you are intercepting this with early and aggressive speech therapy, occupational therapy, physical therapy, vision therapy, any of the therapies, pick whatever they need, you will see that that will sometimes enhance the development to the point that they don't go on to meet that diagnostic criteria. The other one that you need to never miss, is going to be your vision and hearing. So do you remember when do you get that first hearing screen? At birth, and certainly before how many months? Before 3 months, good. And then vision screening, what is that? Remember at what age are those vision screeners down to? How early can you do that? 6 months, yes. Yep, 6 months. And remember, I'm not going to test you on any of these epidemiologic numbers, but just to give you an idea, roughly 2% of your population is going to see this. You're still going to see mild, moderate, and severe. And really, those numbers have not changed for the severe category in about 100 years. Because most of the severe intellectual disability diagnoses have something to do with genetic and chromosomal factors, and those amounts and those numbers have stayed roughly the same. So still see that, and we see actually less in many of the other ones, because of newborn screens. So newborn screens, remember we screen at a time where an intervention can change an outcome. So we've screened for these newborns, and the resulting treatment has often changed the outcome. So what are we going to do now? What do we do for this? What do you do as, what do you do when you are looking at these patients? So yes, you're going to review mom's history. Yes, you're going to review the baby's history. Remember the storch infections, what was S? What was T? Toxoplasmosis. What is the R? Rubella. C? CMV. And H? Or H is H? Herpes. Yep. So you're going to see some of those things going on. A full history and physical, your vision and hearing screen, and then your exam. Are you seeing anything? Looking at growth charts, is this some of the stuff going on? One of your workup then. So again, this is not something that has an absolute specific workup, but it's going to be things to consider. So here's my favorite word again, things that you're going to consider. So urine testing is going to be one thing that you see a lot of for kids. It's going to give you a lot of information. And if you order just a regular urinalysis, you're not going to necessarily see this. But if you order specific urine testing, it can look at, are they wasting byproducts? So do they not have an enzyme that is able to break down amino acids or organic acids? So you could be looking at urine amino acids, urine organic acids, meaning they can't break that down, so it's coming out in the urine. Things that you can look for there. Inborn errors of metabolism, so we don't cover that a whole lot during PA school, but anything that's going to, any of that metabolic process that Dr. Castelline talked about, if you're missing any of those enzymes, you're going to see an upstream buildup of whatever that product is, and wherever that is going to cause problems is what your outcome is going to be. Thyroid, because thyroid can mimic anything, all of your organ differentiation and maturation there. And then do we have any of those chromosomal entities that we talked about, or any of the other ones that we looked at that could be an underlying cause of that? So who are you going to refer to? You're the primary care manager. You're like, oh, I've done the basic workup. It's not their thyroid. There's nothing in the urine going on. Checked for lead and iron. All of that stuff is normal. They're in their therapies, but they're really just not meeting this diagnostic criteria for anything that I can see. So your specialist that you're going to refer to is a specific specialist called developmental pediatrics. This is where I need you guys to know what they do and what they do not do. Because a lot of times you'll see a child who is developmentally behind or abnormal, and so your tendency is, let's just send them to developmental pediatrics. But I need you to think of developmental pediatricians as very similar to geneticists, not similar to therapists, okay? So can anyone guess what the wait time on the economy side is to get into a developmental pediatrician?
2 years.
2 years, yeah. The average is about 24 months to get into a developmentalist. Because how many patients a day does a developmentalist see?
3?
Maybe 3. Most of the time 1. So they're doing full day evaluations with this child to find and meet diagnostic criteria for things like intellectual disability, autism, social pragmatic communication disorder, some of those different type of things. They are not going to be your bread and butter ones that are doing their therapies. So they're not going to have anything other than giving you the diagnosis of a specific developmental issue, much like genetics is going to give you a specific genetic cause, but they're not going to do the follow-ups with all the different therapies and interventions that you're going to do. So that is how you should use developmental pediatrics when you are referring, not telling families that they're going to get right in and get all this developmental help. That is your other therapies that you're going to be referring to. Some mistakes though. So this is when people don't refer. So using this specifically, when do you need to get them there? When do you not? So a lot of people will say, well, the child doesn't look abnormal. So growth, very different than their development. Right? That's why I've spent so much time trying to tease those out. So do they meet the developmental norms or not? Well, their child is walking, so they must be normal, right? That is actually surprisingly common that we hear. And then they're too young to test for delays. That's why we looked at, well, hearing is at birth, vision is down to 6 months, and there's neonatal speech, occupational, and physical therapists in the NICU. So I'm not really sure what too young would mean. Right? So if there is something just wrong on your ages and stages questionnaire, early intervention is going to be your key here. A little bit more time. So we'll go into cerebral palsy. So this one is an interesting, kind of difficult definition because it is non-progressive but constantly changing. So what does that mean if we're talking about cerebral palsy? Meaning that there was one insult, usually one thing happened, but because the child is continuing to grow and develop, it is a constantly changing phenotypic presentation. So it is a non-progressive but ever-changing motor impairment. So that's why it is called that. There's some hit or some lesion to the brain that is causing this. It can cause any kinds of secondary problems from a neurologic standpoint. So this might mean that speech and communication is difficult. This might mean that there are seizures. This might mean that there's spasticity. So it can look very, very different for each child, but it is in some way, shape, or fashion after a hit to the neurologic system. So your prevalence again, 1 to about 4% for any given amount of children. You see this specifically in preterm infants, so this makes sense. Something went wrong and something was early, and the reason that they weren't fully cooked, fully baked, so it makes sense that they're more likely that they are going to have some sort of neurologic hit, neurologic function there. Maternal infection, the reason that that correlates is maternal infection is your #1 cause of preterm birth, which is then your #1 cause of having some sort of cerebral palsy event. It's not just to do with birth, so there are postnatal causes of cerebral palsy as well. So your most common causes is something after birth that is infectious or something after birth that is trauma. So trauma and infections, so meningitis or an early head injury, could be those neurologic insults as well that you see for postnatal cerebral palsy. Child abuse can meet your differential as well, near drowning or near fatal water submersion events. And then neonates can have strokes as well, so a neonatal stroke, certainly much less on your differential, but certainly can happen. There's no lab, there is no radiology that we can do to pinpoint something, so it's really going to come back to what is your history. So history is going to be your most important thing here. And this is where knowing those milestones are particularly important. So when we talked about how old should an infant be if they are rolling? Do you remember how old was it when they could push themselves up and then roll? 4 months, yeah. So if you had that 1-month-old where the parents are like, he's rolling all the time, this is great. You're thinking, ooh, I'm really worried about spasticity, crossing of the legs, early rolling, that's gonna be a problem. Ooh, he looks like he's gonna be right-handed, right? Do you have the right or a single hand dominance that is too early? Remember how old that they're not supposed to have single hand dominance up until? Higher than a year. 18 months, yep. Or if they have some sort of lopsided use where they're not using a hand, right? If you've been around children, so sometimes the lopsided crawling is a little bit of a misleading one. You see babies that all have all kinds of weird crawls, like weird army crawls and weird things with their legs that they do. But if they're not using a specific side, that's going to be one of the things that you will see. So, same type of juvenile management, making sure vision, hearing is good. Is there any byproducts in the urine? Do they need neurology and genetics on board? Because we think that there's some underlying etiology, certainly something to think about. And just to make sure that if you see these terms on the pant or on your tests, that you have a refreshed memory of what this means. So hemiparesis, they are not using one side. They are not using the whole right side, right hand, right foot. Versus diplegia, where they're not using either their legs or their upper body, their arms. So differences there. Or quadriplegia, which is all 4. And if you see different movements involved, just a reminder of what those are. The chorea is more of a spastic response, Cathetosis is more of a writhing, kind of smooth movement. So, just some feedback from some old test questions. What is your treatment goal then? Is how do we increase their functionality? How do we increase their maximal potential? And this is one thing that you might start seeing is different clinics. If you go out into phase 2 or certainly out in the civilian sector, if you're Guard or Reserve here, a lot of children's hospitals will have these multidisciplinary clinics. So cerebral palsy clinics, CP clinics are an example of that. There will be diabetic clinics, cystic fibrosis clinics, trisomy 21 clinics. So these are for the children who have like 14 different specialists, and they would need 27 different appointments over the course of all of these things. So if we just have one day where the families come together and they see everybody at the same time, and everybody can have a multidisciplinary issue or a time, then that's going to be the most helpful for your patients, and probably you as provider to keep everything straight as well. So this is a good place to stop before we jump into autism. So let's start again at 10:30. One was about how, if there's significantly long waits, how are you getting the PT, OT, speech therapy, all kinds of stuff. One of the ways that you can do this under the age of 3, there's a federally mandated program called Early Intervention, so IE or IES, Early Intervention Services. So each state and then this is overseas too at bases, will have early intervention that does in-home speech, occupational physical therapy. Sometimes we'll do trauma therapy or play therapy as well, and they will come to the home to do evaluations and then however much therapy they need for that. So early intervention, you don't need to necessarily refer it. Their neighbors can refer it. They can refer it themselves. They can do all kinds of things. It's covered under Medicare. So that is one option to do. So big plug for early intervention. The second question was, so if we're gonna get some urine on a baby, like how are we gonna get that? Because they don't concentrate their urine, so we just like hold them over a cup, like what do we do? Great question. The answer is under the age of 2, it's a straight cath. So in and out cath. So really good question. We'll talk about that when we get to renal, of how do you interpret results for urinalysis for a baby. But good question then, and then I will look up the other one to get back to you guys for that. Good questions. This class, I will say, your class is some of the best questions of any class I've seen, so keep them coming. So we're moving on to the big looming topic of autism spectrum disorders, ASD. So if you guys have been around medicine for any amount of time, and since you've been alive humans, the definition of autism has changed several times over the years. So the term, you'll still hear people come in and say Asperger's. So that is no longer considered its own entity. It is now considered mild autism spectrum disorder. So the spectrum is large and can have everything kind of housed under that umbrella. So if we're trying to define what is autism, we're looking at deficits in specific domains. So when we said all of the domains were affected, or multiple domains were affected in these young children, that was when we were talking about global developmental delay. It's a little bit different when we are looking at autism. So their gross motor and their fine motor is typically okay, but now their social, communication, and problem-solving domains are particularly affected, and oftentimes you see either a restricted pattern, meaning they don't do it, or a repetitive pattern, meaning that there is a specific way that they are going to do this type of behavior or patterns that are outside what you would typically see for other children at that age. So if you see questions or if you see families, the kind of stereotypic thing will be they have a specific interest in a specific toy, lining them up, repeating, so there's echolalia where they are just parroting back what you were saying. Outside of that kind of 9-month range where you would expect them to do that, they're doing this continuously. And these are those children that on the other side, so you had the children that had no routines. These children have strict adherence often to routines. So when their routine is messed up or something changes with that, this is the child that we can't go to the park today, it is raining outside, we're in the whole day, potentially the whole week. So as an example of something like that. And then different sensory issues. So sometimes it is hypersensory issues, meaning any kind of texture or food change, cloth, jammies, bedding can really just throw them into orbit. Or a hyposensory, where not much bothers them, meaning that they don't give you the typical pain response, and so your exam can sometimes be a little bit misleading. This must be present in early development. So if you are having somebody, I had a commander once ask me if there was adult onset autism for their 23-year-old soldier, and I said, no. So it must be seen in this early developmental periods, and then there has to be some sort of clinical impact, right? If you're saying, my 18-month-old won't potty train yet, well, we're not supposed to be potty training quite yet, right? So that's normal. If you're saying my 6-year-old won't potty train and has no interest, that's an appropriate developmental stage and much later. So that's a clinical impairment. And it can't be explained by an intellectual disability. So that would be the other defining characteristic. And that's where the developmental specialists are the ones that are going to help tease out these different entities between some of these diagnoses. Some of this does have a genetic component. So do you remember what one of the genetic causes of autism was from our chromosomal lecture? Not Williams. Well, Williams does have some of this, but what's the classic one that every child should have? Was it fetal alcohol? Was it Turner's? Was it Fragile X? Fragile X. So Fragile X is one of those genetic causes of autism. But you can see this in higher instances in other things like Williams syndrome. Things that you will probably come up over your time. There's multiple meta-analysis that have looked at all kinds of different studies, and they're time and time again disproving vaccines as the cause. What you will often see is correlations between different developmental periods and an onset of something. So MMR, for example, which is a live vaccine, was first given. It used to be about 18 months, and that is right when this is starting to appear for most children. And so that correlation of your developmental delay with your input of the vaccine is kind of where some of that controversy started. So now we're seeing the exact same patterns of development and the exact same patterns with autism, and we've moved the vaccine down to 12 months. So you really see no correlation at that period anymore. Other things and other different studies that people are looking at that we're looking for correlation as well. So you do see an increased risk in older parents, so both maternal and paternal ages. You see an increase in premature deliveries, so premature birth can cause this. Short interval pregnancies is another one. So that means, have you had multiple pregnancies within a 12-month period, which is just impressive if you're doing that anyway, but it is going to increase your risk of having some sort of autism. And then certainly any kind of prenatal infection is going to increase your risk of that.
Ma'am?
Yes, sir.
With the short interval pregnancy, does that include if you had an early term miscarriage and then got pregnant again shortly after?
No, to
Birth.
2 births. Yes, correct. Again, not just to give you an awareness of how many you are seeing. So 1 in 100, that 1%. We do see this significantly higher in males. However, it will often present slightly different in females. So I think as more of the data is coming out, we will kind of see those numbers shift over time to probably equal. And then you see an increase in siblings, which is showing some of that genetic component, specifically with identical twins. And there's a whole lot of comorbid conditions that we'll talk about here as well with this. So the comorbid conditions, and this is specifically what developmental peds and child psychiatrists are going to be helpful with, is teasing out what is considered a separate entity. So does your child have autism and they have a completely separate sleep problem, like obstructive sleep apnea, or are they manifestations of the underlying autism? So things that you see all very frequently: ADHD, anxiety, sleep issues, toilet issues, and we're talking about the texture issues. So there will sometimes, even defecation can be a sensory input that they really, really struggle with. And so you will see significant and profound constipation in these children, made even worse by issues with that sensory things going on with their diet. So you have a really limited diet, then you have a highly ritualized behavior, significant constipation, and then also secondary sleep issues. And so teasing out what is organic of that and then what is secondary to autism is a lot of where your different therapists who spend a lot of time with these children, and then your developmentalists can help with that. Yes, ma'am?
So these kiddos, are you just gonna permanently supplement their melatonin intake when they're trying to go to bed?
Sometimes, so some of them will be on melatonin indefinitely, or they will kind of have these microdoses of melatonin. Some will do well with just sleep hygiene, some end up with all kinds of different things. So, yes, no, kind of individualized for different kiddos. What age do we screen for autism? 18 months and 24 months, yep. And then what is your diagnostic screening tool that we are using? The MCHAT. And how many red flag questions are there on the MCHAT? 3. And how many of those screening red flag questions are you worried about? 2. Yep, good job. You guys already knew that. Or 3 total. So 2 of the red flags or 3 total of your 20. Do you remember what those red flag questions were? So hands, some sort of abnormal hand-eye movement. What was the second one? Are you concerned that your child is deaf? And what's the third one? Sensitivity to everyday sounds. So, right, does the hand dryer in the public restroom derail our day? Does the vacuum cleaner and upend the week? Things like that. So your treatment, and then what I need to underline star highlight this. I need you to underline star highlight ABA therapy. So over and over, that is the one type of therapy that has been proven to help children with autism. So yes, speech therapy will be important, occupational therapy, physical therapy, but applied behavioral analysis therapy is going to be your key for a confirmed diagnosis of autism. So if you were just guessing, right? How many of you have been to physical therapy here for something in your life? Most people. How many times did you go a week? Once, maybe twice. How often? How long were you there for? 30 minutes to an hour. Okay, so we're talking 1 to 2 hours a week. How long are they at ABA therapy for? All day. Yeah, so typically they will be prescribed anywhere from 20 to 40 hours of ABA therapy a week. So it is considered their full-time job, basically. So what applied behavioral analysis is doing is taking the quote-unquote normal developmental tasks, how to look someone in the eye, how to shake someone's hand, how to ask for water, how to do whatever they're trying to do, and teach those developmental tasks as opposed to having them normally learn developmentally. So you're basically teaching them how to develop. All the other things you're still going to do. So yes, nutritional and dietitians to help with those limited food textures. Yes, there's going to be different types of all the other therapies. And then developmental psychiatric approaches are all going to be different things that we see on board, as well as school. So we'll talk about school at some point here. Which takes us to a small thing about CAM. So if you have been in medicine for very long, you'll hear some about CAM, complementary and alternative medicine. And so this will be something that you as a provider will have to decide where is your comfort level with CAM, because there are some people that says, no, it's not evidence-based, I'm not recommending it at all. Some people are very comfortable with CAM. And so you will have to decide. I've kind of with children landed on, is there harm? Might there be benefit? Let's talk about it. And ultimately, let's try to do one thing at a time. If a family's like, I'm gonna try diet, sleep, supplements, I'm gonna try all these 5 different things, and something helped, now they've just resigned themselves to doing all 5 forever. So let's try one at a time, see what there is, and let's talk about risks and benefits. So as a provider, the things that you will need to know, what could be harmful, right? So in this example, if a kid comes in with a diagnosis of autism and they tell you that they want to do these high-dose vitamins that you know, oh my gosh, they're going to hurt themselves, or we want to do inappropriate chelation therapy, we want to do inappropriate electroshock therapy, something like that, right? Those can be harmful things to the child. They come in and say, we want to try a gluten-free diet. Okay, let's make sure you have the right nutrition on board, and then how can we best support that, right? So determining where you as a provider eventually will sit with CAM therapies is going to be very important. So autism, because we don't have a this is what caused it and this is how to fix it, is one of those areas. Specifically in pediatrics that we see this often. Which takes us to our ADHD. So I think graduate school, specifically medical graduate school, takes people that didn't have ADHD and maybe slightly tendency to it, and makes everyone in this room think that they have ADHD. So we will look at why some of that is. So our number one neurobehavioral diagnosis that we're going to see, again, more slightly with males to females, but again, I think you will see those numbers change, because more females are more of the inattentive type, males are more of the hyperactive type. If you're in a classroom setting, who's going to get more attention? The wild male who's over distracting everybody, or the female in the corner who's dozed and dazed out, right? So you're going to see the difference is with that. Your symptoms of inattention is everything that you feel right at this moment, right? Those are your symptoms of inattention. So all of these things, you might have been the top of your class, and everything else, we put you in a pressure cooker for a year plus. We test all of these systems, and eventually they start breaking down. So one of the things to think about with ADHD in a active duty soldier or in a child is this something that they are capable of doing developmentally? Right? So we think about a day in school. Is it normal and really something that a 5-year-old could do and should be doing to sit still, not make a peep for 8 hours a day? That's asking a lot of a 5-year-old little boy, right? Is this something that is normal to put an adult who's had jobs and done all kinds of things into a pressure cooker for a year and talk at them for 8 hours a day and expect that they're going to retain everything? Also probably not normal. We're going to stress these systems and produce inattention and hyperactivity. Okay? So all of the things that you're like, I hit every checkbox, that is your symptoms of inattention. Same for hyperactivity. You are acting like I have a motor, and most of these things too, functioning adults have come up with their own coping mechanisms. So I can see some of you, even right now, we learn to cope. We're leg tappers, we're fidget spinners, we drink caffeine, we get up and stand up, we have a sit to stand. Sometimes we are doing all of those at the same time. Right? Those are some of the coping mechanisms that we have learned as adults that young children have not. So see some impulsive, see some hyperactive, see some inattention. How do we know if it's really making that diagnostic criteria? So first, you have to have them before the age of 12. So if you're like, I definitely have IPAP-induced ADHD, you absolutely probably do. If these symptoms haven't been there since the age of 12 or before the age of 12, probably doesn't meet the clinical definition. If you're less than 16, you need 6 or more symptoms. If you're over the age of 17 and it started before the age of 12, you need 5 or more of these symptoms. The other 2 things that you will need is it needs to be in multiple environments. So if you're like, I can't do this in school, but the kid is totally fine at home, totally fine at sports, totally fine at Boy Scouts, church activities, whatever, we don't have those 2 environments. And if it's not clinically significant. So if the kid is getting A's, doing well, has a lot of friends, and is a little disruptive, is it really clinically significant? So that's something for you as a provider to discuss with families, teachers, counselors, things like that. And then are other things excluded? So one of the problems you'll run into, specifically based on that history, is we don't have those 2 environments, right? So the teacher will be like, they're absolute disasters, but everywhere else is totally fine. So one of those things to think about is there something going on at school? Is there bullying? Is there a learning disorder? Is there dyslexia? Do we have some sort of something that we need to account for there? Or they're little angels at school and at sports and at Boy Scouts, and they're hellions at home. What is going on? Do we have some parental issues? Do we have some anxiety? Do we have a recent divorce? Is something going on? Something like that going on. So those are home stressors. So that's something to help work and tease out as a provider. We're gonna talk about some learning issues here in a minute. And then your standard screening for this, so we talked about the ASQs for your development, we talked about the MCHAT for autism, and your next one I need you to remember is your Vanderbilt for ADHD. So Vanderbilt are what you're going to look at. So these are your screening for Vanderbilt. I'm going to take your attention because I've did it so many times. The very, very top, this is a follow-up for the parent. So there are initial diagnostic criteria and then there are follow-up ones. I should actually probably change this to an initial one. So basically there are going to be two sets. You need one for the caregiver and then one for an environment where they are learning. So usually a teacher and a parent. Now if mom and dad are both deployed and grandma is your primary caregiver, give it to grandma. So you're looking at a caregiver, and then if they're, let's say they're homeschooled and we don't have any other teachers, do they have a Boy Scout leader? Do they have a church group leader? Do they have somebody else that can serve in that teacher type role? So that is what you're going to use, is the Vanderbilt. Vanderbilts are going to look at some other things as well to screen in or out. So there's psychiatric conditions, things like conduct disorder, learning disorders, oppositional defiance. Some of those things are going to be assessed for as well on your Vanderbilt. So that's what that top part says. Things that we're looking for psychiatric conditions will be on there. Other things to think about. So just because someone comes in and a teacher thinks they have ADHD does not necessarily mean that they have ADHD. How do you feel in class if you didn't sleep well the night before? Kind of inattentive, kind of fidgety, right? So if you have a child with some underlying poor sleep hygiene, an obstructive sleep apnea, you can see those same type of things manifested. What about fetal alcohol syndrome? We said that can manifest as school issues here. Thyroid issues can manifest as everything, so why not here as well? And then some of your genetic disorders, and then some of the home environment. So just a differential of things to think about. It's not just because a teacher or a parent says they have ADHD, do we need to go down that path. Your number one treatment is going to be behavior therapy. So watch out for that. Your parents will love to do that. And we'll say if there is an intervention you can do that is non-medication or contrast studies or all kinds of other things, pick that first. So intervention, lifestyle interventions, pick those first. So this is one of those things I've seen for standardized testing. So behavioral intervention is going to be is first, particularly if you have not started school. So if you are 3 or 4 years old, specifically, behavioral therapy is number one. Routine, we talked about, is going to be the other thing. Consistency and routine, help them understand time as much as you possibly can. Once you do get into your medication management, your first line medications, so after second line therapy, but first line medication is going to be your stimulant class of medication. And even inside your stimulant class, your first line is going to be your methylphenidates, your second line is going to be your amphetamines. So, I think adults, it's backwards, but in kids, methylphenidate, then amphetamines. These come in every way, shape, or form for these kids. So there is liquid ADHD stimulants, there's a patch, there's granules, there's just chewables, there's all kinds of things for these kids. So when you're prescribing, make sure it is appropriate for that age. So if it's a capsule and it's a 5-year-old, probably not going to work. And then your non-stimulants is going to be your next line. So norepinephrine reuptake inhibitors, so atomoxetine or Strattera is one that we see often. And then some of your alpha agonists are helpful for some of the side effects but aren't really great as first for the initial treatment. So if there's some sleep issues going on, you might see things like clonidine added on board, but not as your primary. Things to do. So are these controlled medications or not controlled medications? These are controlled, which means that you have to see your patients face to face at least every 6 months and have some sort of follow-up with them at least every 3 months, just like you would if you had a patient who was on chronic opioids. So you have to have that interaction of patient-provider interaction, at least that amount. Your first thing the side effects that you were worried about, the ones that I always ask and I bring children in for, are you eating? Are you sleeping? Are you growing? So those are your three things that I'm really looking at. Yes, I'm going to look at blood pressure as well. Yes, I'm going to look at school performance. But are you eating? Are you sleeping? Are you growing? So the biggest thing that you're going to see is they're not hungry. And so you don't see this weight loss or this stagnation of weight. And so appetite suppression is going to be your number one thing that you see. Your sleep issues are going to be your number two thing. The rest of those, yes, you will see. The ones that are starred, so nausea and headache, you see those at the beginning, so at the onset of treatment sometimes. You see those typically go away after 1 to 2 weeks. So if they come back at their 3-month follow-up, and they're like, I'm still nauseous, I still have a headache, you're either too high on your dose, or this is a medication they're not going to tolerate. So you should see those go away after a week or 2. Things that persist will be your appetite and sleep issues. Other things, those comorbid things might improve. So you might see that they were a really anxious child, but they were anxious because they couldn't pay attention. So you treat their ADHD, and now suddenly some of their comorbid conditions are much, much better. So you can see that happen as well. So some of those comorbid things improve once you start treating their ADHD medications. And you'll use those follow-ups to make sure that you are on the right path. And so then let's talk about school. So school has some different things as well. So if you've ever heard of an IEP, or an individualized education plan or program, depending on your state, and then a 504 plan. So we're looking at what is the difference between an IEP and a 504 plan. At EF&P, for Exceptional Family Member Program, we'll ask for these, and patients will say, do I need some of this? Or what do I do for some of this? So as a provider, knowing the difference is going to be imperative. So IEPs modify your curriculum. 504 plans adapt it. What do I mean? What's the difference between that? So if I came and I said, hey, for your class, we're only going to have quizzes that are 25 questions long instead of 50. I have now modified the curriculum and modified my expectations for you guys. That is what an IEP does. If I'm going to adapt, it's the same curriculum, but I'm going to say instead of having 75 minutes to test, you guys are going to get 2.5 hours to test. So I've just adapted it. So it's the same expectations with different set of circumstances versus the curriculum itself is being modified. So if you're going to say any kind of educational modifications, this child will need an IEP. If they're going to have adaptations, so they test in a quiet room, they get 20 extra minutes, whatever it is, that's a 504 plan. So modify versus adapt. Be aware of those two different things. And then we're going to hit a little bit of potpourri before we call this one a day. So some of our additional behavioral things. So oppositional defiant disorder. So the characteristics here, this is one that we look for with Vanderbilt's. One things that we're looking for here is, are they outside of that norm, past temper tantrum age, past when we would expect somebody to just be tired, hungry, or sick. And now we have this persistence, this preponderance of the evidence of an angry, irritable mood where they are truly defiant against anything that the parent or caregiver or anyone in some sort of position of authority is saying. And then there's true vindictiveness. Right? So if you have a child that's like, no, I don't want to go to bed, not necessarily oppositional defiant disorder. You have that same child who's saying, no, I'm not going to sit down when the teacher tells me to, and throws a chair at their head, that would be your difference. Something that you would see there. More males than females again. It's something to just screen for on your Vanderbilt's again that would necessitate a secondary referral to a pediatric psychiatrist. Let's contrast that. So we have temper tantrums is one thing. We have just personality traits. Now we have oppositional defiant disorder, ADHD, and then your most extreme version is going to be in your conduct disorder. So conduct disorder, this is now that extreme version of a persistence of true aggression, anger, deceit. Classically on any kind of test question that the PEDS is going to pull out, there's usually some sort of violence towards animals or younger children. So if they're torturing cats, That's probably the most common thing I've seen in a testing type question. They're trying to distinguish, are you looking at oppositional defiant versus conduct disorder? So these children, there's some serious violation of the rules. There's usually, again, some sort of violence towards younger children or animals. Again, high prevalence in males. And once they hit 18, if this persists, these are the kids that get that later diagnosis of antisocial personality disorder. These are the kids, so if you're thinking, I'm just gonna send all my ADHD and all of my autism off to see PEDS psychiatry, that would be incorrect. So in the typical ADHD realm, in the typical school environment where they need some different educational help that is going to be on you as the primary care PA. These cases where you really think that it is oppositional defiant conduct disorder are going to go over to PEDS psychiatry. So this is going to account for 1 in 3 of all of their cases after you screened with the Vanderbilt, and they are going to then work with those families for the appropriate treatment. So ODD, conduct disorder, outside the realm of a primary care PA. Autism, ADHD, inside the realm of a primary care PA, unless you're something is arising that's outside of that. Oh, we got through 10 of these. Let's do a couple of check on learning. 8-year-old female is having some trouble in school and she undergoes educational testing. She's found to be dyslexic and requires a quiet testing space and is allowed extra time. Does she need a 504 plan or an IEP? 504, good. Questions, problems, concerns, anxieties, frustrations, grief, miscellaneous tasks. Have an extended or a happy lunch. I hope you guys get early done today, and we will see you next week.